to the partners meeting in December for the PD Avengers. We have about 30 participants today so far. I imagine we'll get another 10 or 15 as the time goes on. This is going to go 75 minutes today. And if you can't make it the whole time, I understand. We are recording this, so I'll have a recording available. And then today we've got a couple of presentations. The first one is going to be with Sonia Mather, and she's going to take us through equity and medication. The team from Synapticure is here to dazzle us with what is revolutionary new way for caring for people with Parkinson's. So with that tease, I'll hand it over to Sonia Mather.
Thank you all for being here. I'm so happy to see so many people that were able to take the time out to be here. I've always been sort of involved with living well with Parkinson's disease, you know, clinical trial recruitment, the importance of the patient voice in research, women in PD, and so on and so forth. But it was really through my involvement with the PD Avengers that I became connected and made connections with other parts of the world. And I really became much more aware of the inequities in terms of care for many parts of the global community, the lack of sometimes very, very basic minimal care. And it is out of that recognition and of the fact that we are a global PD community, and from my own sort of personal view that when you know better, you got to do better, that we started this medication equity group. And it's a group of like-minded individuals who are really looking to see how we can support our existing partner organizations and sort of think outside the box, how we maybe be able to address, in the first instance, this issue of the lack of simple dopamine replacement in some areas of the world, starting this time with Africa. And you'll see that this is really only one part of their very, very much more complex issue. So we're going to start off with Natasha Fothergill-Misbah, who a lot of you know. She's a lecturer in gerontology, has a background in biomedical sciences and global public health, has done a vast amount of research and is soon to do more in this area. And then Tanya Park from Parkinson Africa, who's the new, very, very capable, recently appointed CEO, working with Omotola, will speak after that. And then Nitish Sharma, who is the chair of the International Affairs Committee at the World Parkinson Program, will discuss a little bit of his work, and then we'll open it up to questions and discussions. So thank you all for joining us, and I'll turn it over to Tash.
Great, thank you. Can you hear me okay?
Yes.
Perfect. So thanks. Yeah, I'm a researcher based in the UK, but as Sonia said, most of my work has been, my advocacy, research, interest, policy work has been in Africa. So I was fortunate to work with the WHO recently on some things that I'll highlight in the next couple of slides, but I just wanted to outline the kind of overarching situation that we're facing or we're dealing with to set the scene for this equity group. So in terms of care, I know we're focused on medication here, but kind of care overall, we know that there are 0.03 neurologists per 100,000 population in low-income countries, and this compares with 4.74 in high-income countries. So we really have a lack of people able to actually diagnose Parkinson's, which is kind of the first step towards getting people diagnosed, getting people prescriptions and accessing medicines. Then if we have people who are diagnosed, fantastic, minimal number of people who are diagnosed, but then they have this issue of actually getting the medication that they need, that, you know, whoever with Parkinson's needs to live well. So we know that levodopa is consistently available in 0 low-income countries in the world. And that's a recent publication by the WHO this year. Even where it is available, if it is available, usually in kind of urban areas of the continent, it costs too much. So people can't actually afford it. So they've got a challenge with it's not really there. Even if it's there, it's probably not in reach of where they are. And then when it is, they can't actually afford it. So, oh, sorry, there's some unmuted interruptions. So we know that a 30-day supply of levodopa basically costs a whole month's wages in Nigeria, and similarly in Kenya, where people have done some studies. And a study, a review last year determined that PD-specific therapies and services are largely unavailable, unaffordable in most African countries. Bottom line, basically. So this is the kind of context that we're working around. Sonia, if you go to the next slide, please. But I guess it's important to acknowledge that it's not just us. We're not just kind of, well, we kind of are just trailblazing and trying to fix this problem, but there are higher level organizations that are also working on this at a different level. So at this higher level, the WHO have been acknowledging Parkinson's as a problem kind of worth addressing. So this public, in the middle there, you'll see the Parkinson's Disease, a Public Health Approach technical brief, which was published this year. And this is being kind of within the context of, on the top right, you'll see the draft intersectoral global action plan on epilepsy and other neurological disorders. So this begins this year for 10-ish years. So with these two kind of documents and then the paper that was published off the back of the technical brief on the left, really WHO is acknowledging neurological disorders in general, but also Parkinson's as a problem. So as well as that, the WHO, oh, actually, Sonia, if you go to the next slide, I think. It's been a while since I put these together because we were supposed to present in November, so I'm catching up as we go. So in terms of the technical brief and actions related to medicine specifically, the WHO really highlighted these kind of bullet points. So first and primarily is an update on the National Essential Medicines list. So they're working on this at the moment and trying to identify which countries in Africa have essential medicines list to start with, which ones have any any Parkinson's medications on their national essential medicines lists. Do they match with the WHO's essential medicines list, and where are there kind of gaps where we need to address? So that's the high level stuff that we kind of need that before we can trickle down into the other steps. And the other actions are to modify legislation to increase access to generic medicines. So this may be in-country registration of drugs, for example, but we also want to promote local manufacture of medicines to kind of negate that import issue. And then, yeah, register medicines with registration boards, which will improve the availability. So instead of parallel importing based on need, we actually have that constant supply of medicines coming in, because if we think about need and the business model of need, we actually don't know how many people live with Parkinson's in a lot of places in Africa. Therefore, we can't really say that there's a specific need. And then we kind of go round and round in circles of this unavailability, unaffordability, etc. So next is to revise the WHO essential medicines list as well. So update that with kind of other formulations of levodopa, which aren't currently on there, and more recent treatments, if any. Negotiate with pharma is on the list as well. So see where we can work with pharma to maybe create those business models and kind of chains of supply into African countries, and then generate evidence needed to feed into procurement and supply chain management. Those concepts are beyond me, so I'm hoping people with the pharma knowledge understand what that means. I think maybe one more slide, Sonia, or is that me done? That's me done. So basically, it's there's a lot of work to do, and we're kind of working at lower, well, potentially middle and lower tiers of this challenge, while the WHO is kind of working at that top tier of making that policy that they can do. I think that's probably everything in terms of setting the scene. And obviously, organizations like Parkinson's Africa are doing lots of exciting things and helping people on the ground to fill this gap. But really, we need a kind of long-term solution. It's incredible that we can provide access to medication for individuals short-term, but we need to find longer-term solutions for everyone, not just the groups of people who we kind of interact with, so that anyone, even if they're not linked to PD Avengers or Parkinson's Africa, can access affordable treatments. So I'll hand over to Tanya now.
Thank you so much, Tash. Thank you so much.
Hi everyone, my name is Tanya and I'm here to represent Parkinson's Africa, a UK registered charity that provides advocacy, support and education to people impacted by Parkinson's disease in Africa. And where possible, we try and facilitate or help people access medications for Parkinson's. We're a fairly new organization, so we've only been running for a year, but we've made some very firm partnerships with 7 African, and we operate in 7 African countries. And the reason why I wanted to sort of start with this diagram is really to very much show you how we would like to operate going forward. And it is very much focused on building capacity with partners on the ground, and in particular helping recruit, train project officers, trained community leads and health professionals who can then go off and work with beneficiaries and with the right sort of support and access. We hope to be able to see some improved knowledge, attitude, behavior, and as a result, sort of have a long-lasting impact. So this is kind of a high-level context overview of what we do and how we operate. And when I first started with the organization a couple of months ago, as Tash mentioned, I tried to really access some data, figures, numbers, how many people live or are diagnosed with Parkinson's in each country. And I struggled to find that. But what I wanted to do is really, from my point of view, to understand what it is, the scale of the problem that we're dealing with, and try and kind of articulate that in some sort of a visual format. So Sonia, if you may please go to the next slide. Perfect, thank you. So I've created this diagram, and I won't go into great details in every aspect, but what that shows is really the core problem and this is really gathered through qualitative discussions with partners and colleagues. And what we've discovered is really people impacted by Parkinson's disease have poor quality of life. And we've identified 4 key kind of direct causes, which is very much linked to lack of awareness and understanding, the knowledge about the disease, lack of support and lack of clinical services, which is very much linked to the discussion we're having today. And obviously there are a lot of contributing causes that have already been mentioned. And if we look at the direct symptoms and high-level symptoms, this all leads to some of the problems that we see and we hear, which is very much sort of stigma, exclusion, limited life opportunities for many people, and sort of decreased physical and mental health, and sometimes lower chance of survival if they haven't got the right sort of clinical support and medication. So with that in mind, what we thought is we were like, okay, well, we think this is what the problem is, and this is a vast need. We've turned this into a solution sort of framework. So Sonia, would you mind just clicking on the next slide, please? Thank you. So in terms of what we really want to see is we want people impacted by Parkinson's. Well, what we really want to see is cure for Parkinson's, but obviously that's not something we can provide. But as a charity, we want to see people impacted by Parkinson's disease living empowered and healthy lives. And we figure that by providing more sort of advocacy, awareness, more education, more support, and improved clinical services, this could really lead to some of those outcomes that we as an organization would like to work towards, which is very much the direct impact line. Now, we're only a small organization, and of course, many of these outcomes would be much harder to hit. But this is what our vision is. This is what we'd like to be able to tackle in the next 5 years, 10 years, etc., and consistently. And I guess what I wanted to really kind of bring to more kind of channel our discussion towards is really, if we actually, Sonia, if we could please go back to the first slide where the theory of change is. The next one, yeah. So I guess from our point of view, our change makers are really the trained leads and the community professionals, as well as those support services that are supporting the beneficiaries at the bottom right. So if, and this is where we would really struggle the most, because we don't have any kind of health or clinical expertise within kind of our charity. If we could find support services where we consistently could work alongside whilst training our project officers and providing that sort of education to those health professionals so they feel equipped, they could be the right foot soldiers, the right messengers to work with our participants, and with the right services, we believe we could really collectively make a difference. And just to sort of put this back into a context, recently we've done a sample data collection in Uganda, in a rural area in Uganda, and we've reached out to 35 people, and we've discovered 17 of those people have been diagnosed by a medical professional. He was a neurologist, but was trained by a neurologist. However, those people have never had any follow-up consultations. They've never had the means to or any access to medication. And the other 15 or 16 people we've spoken to, we've identified they've got symptoms, but again, just to be able to signpost them or bring them to an environment, to a medical professional to be able to help them, it seems like a real challenge. So I guess to really wrap my sort of presentation up is we as an organization, and touched on something very, very important, evidence. What we would like to sort of work on, and what I would actually love help, in addition to anything that any colleagues could sort of contribute and help us really provide sustainable solutions around any of our kind of programming aspect would be amazing. But what I'd like to do is I would like to be able to build a system where we could really start gathering evidence, collect the right information to be able to present the problem in a quantitative, evidence-based way to really show people that where the real issues are and where the real gaps are. And we've already started sort of collectively with quite a few colleagues to really build data collection tools and various sort of questionnaires and systems to be able to support that. So thank you very much.
Thank you so much, Tanya. That was great. Nitish?
First of all, thank you everyone today for coming here to hear from us all. I'm here on behalf of the World Parkinson's Program. I am the director, I'm a director on the board and the chair of the International Affairs Committee. And just wanted to provide a little overview on the World Parkinson's Program, what we do, as well as some of our, well, I guess frankly, our most notable sort of activity, and understanding better if folks here have any suggestions or just better understanding and wanting to support this initiative. So without further ado, I mean, it's highlighted here, but the World Parkinson's Program is a registered Canadian charitable organization with a mandate to improve the quality of life of those suffering with Parkinson's disease around the globe through providing free medication, education, and other assistive devices to those in need. And so by and large, we spend most of our time in support of individuals in developing nations. We find most of the need in African and sub-Saharan African countries, as well as countries in Asia. And our approach involves helping those people specifically through provision of free medications, levodopa and carbidopa, particularly to those who can't afford it. And then we find the needs as well and try our best to support provision of things such as canes, walkers, wheelchairs. We also have educational brochures of all sorts, helping people who are suffering, as well as caregivers, with advice and understanding of Parkinson's disease. And we've been fortunate enough to find volunteers to help us translate those into 20 different languages. Question from Katsura, I think topical given what I just said. Are they in Japanese? I don't believe we have Japanese as of today. And so if Katsura, you're aware of anyone who would be willing to help us with translation, happy to provide the actual underlying documents to help achieve that. We also have an electronic newsletter that we provide on a monthly basis to folks around the world to just keep up to date on the goings on. And one of our unique traits amidst the provision of medications and walkers and even those educational brochures is our chapter model. So we actually find, and we'll get to this on the next slide as well, but we find neurologists, folks on the ground in these various countries who are very focused on supporting those with Parkinson's disease, and use them as a kind of lightning rod, providing their contact details, hopefully, as well as a place of or organization to have folks who do stumble upon us online or otherwise to find a resource locally and find someone to connect with. And then lastly, we actually support educational programs, exercise programs for those who are fortunate enough to live in Canada and in Toronto specifically, and want to take advantage of that. So on the next slide, I cover off the overall medication program, and I highlight the various process steps. This is not a slide that is as visual or as exciting as some of the previous slides you'll all have seen, but try to highlight the process steps as well as the pain points we're seeing in the process. So oftentimes, it can seem like we're doing something, fairly simple or even fairly challenging, which is providing medications to people on the ground. We do receive fundraising from a number of different sources, both individual as well as institutional or corporate, and a lot of fundraising is out of Canada, given our local connections. But this is the method by which that money turns into medications for those who are in need. So a lot of detailing slides to kind of cross over some of the key points as well as the pain points actually. But by and large, the first step for us is to find a local neurologist or movement disorder specialist. And this is a kind of requirement to find someone. And overall, a lot of our process steps are geared towards just confirming that we're doing the right level of diligence and finding the right individuals. Given our registered charitable status, given our kind of regulatory overhang from the government of Canada, specifically through the Canadian Revenue Agency, just to maintain the tax advantage status, we have to ensure, and also frankly, just for the benefit of everyone, ensure that we're working effectively to document and find the right people and demonstrate we find the right people along the way. So we ensure that we find a neurologist, movement disorder specialist, frankly, because they're the ones we understand to be the best suited to identify those people who are in need and to be the right arbiter of who should receive medications when we provide it to them. So from the neurologist standpoint, we try to make it as easy as possible, have them sign a service agreement. That's just a legal requirement for us to ensure that we're sharing the risk appropriately. But we also do diligence to ensure that they're who they say they are. So we obtain their biography or their resume and the medical license information. And we've had occasions where less than, we'll call it genuine participants have come to us and said they were neurologists or said they were part of our organization and essentially trying to obtain free money. So this is an important step to just ensure that we're finding a real neurologist. But oftentimes we never physically see these people, even over Zoom. It's a lot of communication over email, a lot of communication over WhatsApp and telephone. And so to the degree we can use documentation and do third-party verification is quite integral to us. The next step is actually one of the major points around the medication sourcing. So once we, Peter, I'll get to your question. I'll let you read your question. So we haven't yet done that, Peter. Work with telehealth movement disorder specialists. I would be very keen on exploring that angle. I mean, we've talked a lot about, and so far I've talked a lot about the support of those who are in less well-to-do areas, but we and I haven't mentioned really support of Canada and the US, but we would help folks who are in need in those areas. We find that the medication need or the financial need is not as strong as educational need and just living with the disease sort of need, but really happy to talk about that telehealth piece and still support those who are in need.
I may have derailed the question a little bit too and misled. I think more of the using US-based staff or Canadian-based staff to help in Africa as well too, if there's a way to do that in the future. We'll get to what we do later on. But very, very curious.
Maybe
we'll have to connect.
Nitish, is we'll just wrap this part up.
Sure.
If you could just lead through maybe high level what else the process involves, and
Yeah.
then we can take the questions because I know you have to go as well.
Appreciate that. Yeah, I've really been a bit verbose, so I'll kind of focus on the pain points. I mean, through this entire process, and I'm happy to share the slide as well, we know two real issues, well, challenges we have in terms of delivering medication. The first is medication sourcing. We put a lot of potential burden on the neurologists, and sometimes they shy away, but one of the features or needs we have for them is locating a local pharmacy. Just finding a local pharmacy that can provide medication in the city, in the country, to the neurologist solves a lot of customs or kind of import issues that one might face. We've had issues whereby medication has been seized at customs when we brought it from a out-of-country source. So finding that need locally is helpful, but even if we do that, we often find the cost to procure is higher. So that's why we even have explored and have oftentimes attempted to have an out-of-country source provide medication because it's just cheaper. And so, ignoring shipping costs for a second, we found that the cost externally, just from both Nigerian and Ghanaian sources, can be as cheap as 15 cents a pill for cinnamon, or $15 for a box of 100. And then it could be 2 to 3x that in a local source. And thank you, Jamie, for your suggestion there. We'd love to connect on that basis. And just to wrap up this discussion on the release and shipping side, so in those cases where there is no local source, I'll throw Uganda as an example, where we just can't seem to find medication that is about the $15 price point for a box. It ends up being 2 or 3 times the price. We would love to be able to ship medications. We have sources, and the Nigerian and Ghanaian based, and ideally even a Pakistani based one, but we run into trouble whereby we have to ship those medications and go through the customs process. The export customs generally are fine. It's the import customs in certain areas that have been problematic. And one example is Morocco, where we went through the process. We attempted to, based on the neurologist doing the legwork, understanding what the import requirements were, and ultimately were unable to have medications be released from the customs in Morocco. So if folks have suggestions, support, or can support this kind of piece around the logistics of local government customs, they'll be really appreciated. But all to say, those are some of the pain points, and overall, we're able to provide medications on the basis. So I'll stop here. Thank you for the time, and happy to answer your questions.
Thank you so much, Nitish. So, as we all can see, the need is there. It's an urgent need, and it's not a need that has an easy solution, but there has to really be a solution for us to improve quality of life for these patients. They're part of our global community, and we need to commit to do that in some way. And it's not about giving a man a fish. It's not even about teaching a man to fish, because there are experts, although not enough, that already know how to fish. But it's about giving them the opportunity to fish in the same ocean that we all have the privilege to fish in. And it's all about collaboration. And so now I'll open it up if there are any questions, any experience you may have to share, any advice you can give, how we can proceed, and that would be greatly appreciated.
Hi, Sonia. It's Amber.
Hi, Amber.
How are you? Hi, everyone. Hi, Nitish. I just had a question. Sorry, I came in a bit in the middle. You were talking about education, and which is quite broad. So I was just wondering, what were the top priorities? What were you trying to deliver from an education perspective?
Yeah, happy to answer that. So for educational perspective, and I won't do it justice, some of my partners will be a bit more suited to explain, but by and large, when we say education, we're talking about, what is it like living with Parkinson's disease? And we've been as granular as, what does movement look like with Parkinson's disease? How does eating work with Parkinson's disease? How does sleeping or just the progression of the illness, what can one expect in that context? And actually, a lot of our education material is written initially by our founder, Dr. Abdul Rana, who's a neurologist here in Toronto, Ontario. And he's the one who just has the knowledge base, wrote it initially in English and I believe 2 other languages, but then it's further proliferated. But I'd be happy to share a link actually with our, all brochures are available online, free of charge to download and print as you please. I'd be happy to share that kind of full link to see the library of educational support we provide.
Yeah, that would be great. And just so I'm clear, you're saying the number one priority for you on education is to tell the patients about the symptoms they're going to be experiencing. Is that it?
Yeah, and so, I mean, by and large, if they have a neurologist and that they can explain it, it's great, right? They can get that guidance and they don't really need brochures per se. They can talk about their individual needs, but it's mainly to help those who may not have access to the neurologist, may not have access to those who can provide that one-on-one support. So we do find a lot of the local Parkinson's organizations that are focused around just supporting outside of the medication need. Take us up on the offer. We'll print in handed out pamphlets to people who know they have the disease, who may think they have the disease, and even some neurologists as well who want to just give a quick kind of primer to share with their patients.
Great.
Yes,
Thanks
it's
for that,
question. That
Kari.
is what it is.
Sorry, Tanya, did you have anything to add to the needs that you might have?
Yes, I mean, we sort of started really looking into this into more details, and right now actually we're working on an educational project whereby we are developing a walking football coaching manual where we're and we've got some funding secured for a project in Nigeria where Tash is actually very involved with as well, whereby we would like to promote the health element, try to get people involved in a physical exercise, coach kind of the physical element, but marry this into a Parkinson's disease element. So this sort of can provide, this is kind of my background anyway. I come from kind of HIV background, working in Africa where we've used football as a development tool. So the plan with that is really to really help people understand and learn as much about Parkinson's disease as possible over a period of time through a fun and engaging way. So instead of really giving them a booklet and say, oh, here's the symptoms that you might be experiencing, we want to get everyone in a support group way, use walking football as or boxing or exercise as an icebreaker, do a little bit of physical activity and then marry it or kind of illustrate it through how this might portray it in the Parkinson's world, Parkinson's disease world, and then sort of have a discussion and enable people to be able to learn. And then over the course of the week, they could then talk about this particular topic, for example, symptoms. And then the following week, we've got another topic. So over the course of 6 weeks, we're hoping to see, and we would measure the knowledge at the beginning of the course and then at the end. And we hope to see improved knowledge and more kind of substantial education about the disease, so people could be happier about some of these things, but it's learned in a different, slightly kind of way.
Thank you very much, Tanya. Yes, Carol has a question.
Hi, everyone. I'm listening, trying to listen so carefully to Tanya because we have in this country so much of this already done. It's just a matter of hooking her up with some of the people that have already created this to help her work with it. And I think of those wonderful publications that APDA and PF has had for years. They have and they're all on their website and they send them out to people hardcover. It's free. And it covers all motor and non-motor and meds and exercise and nutrition and everything. And the other thing that comes to the top of my mind is that we've worked for years with USC, with Giselle Petzinger and her husband. They have done so much work on exercise and they have done so much connecting with those people or whatever. I mean, I'm just trying to think it's so frustrating to hear this when I know everyone in the States has access to so much education. In fact, there's really a lot of duplication. There must be some way that we can help hook her up with some of these people that have already done this. Does that make sense?
Yeah.
Yes, that's the whole purpose of this whole meeting.
Exactly. I
Thank
mean,
you,
there will be
Carol.
some additional challenges given the cultural nuances and language issues that would have to be overcome. But you're right, we do have a lot of resources that we could share.
We do, but even to a next level, Sonia, usually when you ask these people for help, they're wonderful. And to, have like several ambassadors, if you will, one from USC and one, all these people that, Davis Finney does a lot of work in exercise too. So some of these people that have done a lot who could help work with Tanya to make something that would work for where she is. Just a thought. I just, it's just so frustrating to know. Sometimes I say there's so much duplication, but I know everyone needs it. But if we have so much, there is such a need right there that by working with some of these wonderful people that have created this over the years, that there must be some help right around the corner. Has to be.
So Tanya, take everybody's name and number.
Yeah, thanks so much, Carol. That's wonderful. And I know, yeah, absolutely. I would love any help and support. It's just one thing I wanted to, and Tash and I, and sort of, we're just starting with this project, but what is really important, and I've done work in Africa for 15 years, mainly through football, and when we first started, we gathered loads of materials and we went out, but actually what we really need to kind of really tune in is the cultural difficulties and the challenges, and really go out and explore what it is walking football going through, and that's why in a way we are sort of developing things, but really the final product will be after a pilot is delivered and worked with a local partner, because it needs to be sort of a higher representation of the African population, even in the materials. It's really, really, really important. So I would love any recommendations, any contacts that you could send.
All right, Sonia, I'm going to send you a few names and contacts.
That would
and
be
by the way, use my name. Say I told you to call.
Excellent, Carol. Thank you as usual. You've been great. Thank you so much.
With just a little funding to help these people work together and maybe make an incentive, I have to believe that would just leapfrog her several steps ahead. So I shall send you an email in the next day or so. I'm going to try and think of some more people.
Thank you. You're right. It's no use reinventing the wheel if we can just
change it
a little bit to suit this issue.
And to help create the wheel so that it meets Tanya's and the country's needs.
Exactly. Yep. So anyway, as I said, think on it. And if you have any ideas or advice or experiences that you can share, then please don't hesitate to get in touch with. You can send everything through me or to Tanya directly or Tish, but if you send it to me, I'll make sure it gets to the right place. Because I guess, if we know better, we got to do better. And this is really something that when it affects one part of our community, it really does affect us all. And we need to collaborate to get some relief for patients, not just in Africa, but globally. There are many communities that need our help. Thank you.
Thank you, Sonia. This is why PD Avengers exists. This is why this call exists, for these types of conversations. So it's really exciting to bring forth that discussion, and I'm really excited to bring forth the next discussion, which is our newest partner, Synapticure, which is a company that was born from the ALS community and is now working in the Parkinson's community. I'm going to bring in Dr. Jamie Hatcher-Martin, who many of you may know as MDS, formerly at Emory and elsewhere. And we've been on stage together a couple of times for Michael J. Fox events. And Jamie, why don't you take over the floor and introduce your crew and talk about what Synapticure can do for these folks.
Absolutely. Thanks, everyone, for having me and for being here. So as Larry mentioned, I'm a movement disorders neurologist. I'm the director of movement disorders for Synapticure. And I'll quickly just, I don't know who else is on the call. Sandra, if you want to go next and just a quick introduction.
Yeah, absolutely. Thanks, everybody, for having us. I love the phrase, when you know better, you have to do better. I think you'll hear that resonate throughout our story today and our experience with ALS and moving to support families with a whole host of neurodegenerative diseases. But my name is Sandra Abravaya. I'm serving as CEO of Synapticure, but probably most importantly, I've been a caregiver for my husband for 5 years since his diagnosis with ALS at the age of 37. Brian is here as well. Brian, due to ALS, can't lift his hand to say hi, but he's in a box down here. Brian Wallach. Oh, there you go. Screw you, ALS. That hand went up like a couple inches. There you go. Brian and I have teamed up over the last year with Brian's brother, Peter Wallach, and we have built out the team to a really phenomenal group of physicians and practitioners that Jamie will sort of share more about. But Peter Wallach is the company's CFO, and then Evie, who's also on this call, is living with a family member with ALS as well. So we are a, patients for patients kind of company, and we approach care really differently, and excited to talk and share about that today. So Jamie, I don't know if you want to share screens and put up that first slide. And so I'll just say a quick word about our background and then turn it over to Jamie for the bulk of the presentation. So when Brian and I were diagnosed with ALS 5 years ago, we had come from a background in government and advocacy. Brian and I actually met on the 2008 Obama presidential campaign. We worked in President Obama's White House together. And when we were diagnosed, we decided that we were going to co-found a nonprofit advocacy organization called IAMALS, which over the last few years, we've been really focused on driving up federal funding, and are proud that essentially we've created the equivalent of the amount of money raised through the Ice Bucket Challenge. We've generated that in additional federal funding over the last few years. So I call it sort of the silent ice bucket moment that is repeating itself every year. We also wrote legislation that became law exactly 1 year ago. President Biden signed Act for ALS, and it is essentially legislation that gives ALS patients access to therapies after phase 2 trials through an expanded access pathway process. So that's all to say, Synapticure is a newer endeavor of Brian and mine over the last year. However, it's built on the foundation of 5 years of experience being very deeply entrenched in this space. And obviously, as part of that, not only getting to know ALS families and the pain points in ALS, but specifically getting to know the Parkinson's community and the pain points in medical care in Parkinson's. So obviously the most amazing thing I have to report is that we were able to recruit such an all-star in Jamie to lead, design, develop, and execute the launch and the expansion of Synapticure into Parkinson's. So over to you, Jamie.
Thanks, Sandra. So just want to tell you a little bit about kind of who we are and what our goal and our ethos are. So I'm preaching to the choir when I say that for many patients in the US and Canada, and obviously in many other countries, the journey for diagnosis and treatment for neurodegenerative diseases, including Parkinson's, can be really expensive. It can be very complex. And there's, there's a variety of things. In the US, there can often be 3 to 6 months or more waits to get in to see a physician. At my previous job, it was about 9 or 10 months out to be able to see a neurologist. Patients often have to travel significant distances to get to see a specialist, and many will never actually see somebody who's trained specifically in their disease, and they may never have access to any clinical trials. And in addition, once they get into clinics, there's often delays in care because there may not be genetic testing available, which again, they may not know they're eligible for clinical trials because of that. The clinics are just so overburdened right now as it is. And because all of the services aren't available, often they're having to refer out for multiple services, and that further delays treatment and diagnosis. So the solution for that was the development of Synapticure, which is a full clinical team of neurologists, care coordinators, genetic counselors, and insurance navigators We're partnering with top academic medical centers and community neurologists to really provide expert care for patients in their home. So really trying to bring care to patients, not have to bring patients to care. We do offer genetic testing and counseling in relation to that, and a centralized portal where we gather all the records that patients have and put them together so that they have access to that, all of that information in one location. So the goals are, we just recently expanded into Parkinson's disease. So the goals are to help expand care to people living with Parkinson's disease right now who are not able to see a movement disorder specialist. And then to streamline referrals to, in-person or boots on the ground movement disorder centers to really be able to collaborate with them and help supplement care in those clinics when able. We also really want to speed referrals and recruitment for clinical trials, and then patients who may be eligible for advanced clinical therapies, so things like DBS or focused ultrasound, really make sure that we're referring them when they're eligible for those options. And we're using feedback from patient and care partner panels to really make sure that we're partnering and kind of guiding our services, make sure we're doing things right from the get-go. It's one of the big reasons we wanted to partner with PD Avengers, is we wanted to have that input from the get-go. So this is just a quick summary. I won't read all of it, but a quick summary of the services that we're currently offering. We will help patients arrange local services like PT, physical occupational therapy, speech language. We help with the clinical trial eligibility and referring for enrollment when appropriate. We do help, as many know, our insurance system is extremely complex in the US. So we have an insurance navigator that really helps with a lot of that and getting authorization for medications and working through denials when those medications are denied. We really do a lot of education around medications and what they're used for and what to expect from them. And then a lot of our patients are interested in supplements as well. So we're willing to talk through those and the science behind those as well. I mentioned the genetic testing. One of the big things we focus on is frequent visits, more frequent touch points, so that if things are getting worse or there's symptoms that are going on, that we can address those before they become a more troublesome issue. And we're also getting involved in a few different remote patient monitoring programs where we can monitor things like breathing status, movement, falls, weight, tracking weight at home. And, it came up before, but one of the biggest things we do is really education about disease basics and, why we're doing the treatments that we're doing and why one person might be eligible for a treatment and another person might, do better with a different type of treatment.
Jamie, is it okay if just we go back to that last slide for just a moment?
One more?
No, the services offered. So I just want to give the perspective that Brian and I have come into over the last few years, which is that this is about helping patients in their moment of need proactively, right? We don't want patients to feel like they currently do, which is that they have to go to an in-person clinic for every single little adjustment or point of need, when, we've all seen firsthand that that's not absolutely necessary for better care, right? There's so many things that you can access and get help with via these virtual visits. And really importantly, Brian and I observed that these are essentially approaches and supports that exist in every other disease space, and neurology has been left behind. There hasn't been a national platform that has provided what cancer patients get today in this manner. And so we're trying to bring essentially the very same approach that is happening in kidney care, in oncology, to neurodegenerative diseases. And so I wanted to just kind of give that additional context and color. Back over to you, Jamie.
Absolutely. So currently, we're licensed. We have physicians that are licensed in 45 states in the US. We have the other 5 are currently in process, as well as Washington, DC. So we'll soon have national coverage. And one of the things that we really want to focus on with the physicians that we're working with is that we really are meant to complement the care that patients are already receiving. We're not meant to replace in-person clinics. And so we routinely share our medical records. We can set up care conferences with the clinics that we're partnering with, so we can share information about patients or particularly troublesome cases. Again, we're extending the services that clinics may be able to offer, such as remote patient monitoring or different types of therapies. We take on a lot of the burden of the prior authorization and appeals that is a big issue in the United States. And we can also, by partnering with these systems, we have access to, a lot of the physicians that are sort of boots on the ground. So as we have patients that do need in-person therapies, we can, try to help expedite those appointments as well. And these are just a few comments from some of our partner physicians that we've talked to already about how this is the future of how we deliver care. One said this has got to be too good to be true, and how having this service available to really be able to touch in when needed could dramatically change patients' outlook and their quality of life. And that, even though sometimes they have services where they can try to get patients in quickly in person, that sometimes patients, especially complex patients, may really need somebody with the subspecialty training to understand all the nuances. So this is just a summary of some of the things that some of our patients have tweeted out or put on Facebook and social media. A lot of it has to do with how easy and how quickly we've been able to respond to a variety of things, being able to get medications approved that had been denied multiple times in the past. We've had a lot of patients refer other friends and other patients to us, so a lot of organic growth based on how happy they are with our services so far. And that we've, even in cases where patients are already, towards the end of their life, they're already on hospice, that we've still been able to be a lifeline for them. So at the end of the day, the goal is really, again, like I said, to bring care to patients. We really want to reimagine the care and the treatment system because the way it's working and the way it is right now is just really not working, and really build it around patients and their families and their needs. We do go through insurance in the United States, so we're trying to really limit the cost for patients. It's really important to us, and provide a ready access to a wealth of information and education. So with that, I put it in the chat, but just also wanted to mention we do have a Twitter Spaces event tonight. It's at 7 p.m. Eastern time. So we would love if anybody here could join us tonight, and if you'd be willing to, I put some language in the text. If you'd be willing to share that with other people as well, we'd really appreciate it.
Yeah, and let me just build on some of what Jamie was just sharing about the physicians and the patient community in Parkinson's that we've been, developing with. It's interesting. This is what we're seeing in Parkinson's, and obviously what Brian and I experienced firsthand as a patient and a caregiver in ALS. But, physicians think that they're doing everything right, and yet patients aren't happy. And it's because doctors expect to see patients once every 3 months, and they're, these physicians are working hard, 120 hours a week sometimes, and their heart is in it. But at the end of the day, patients need more than the current system is allowing for. At least Brian and I feel like we need to see our physician once a month, once every other month, at least, be able to send a message, get an answer on demand. And that's just not the way that the current care system is set up and is supporting families. And in any case, it's, also really important to Brian and I that we're democratizing care. And so everything is about working with insurance. We've worked hard to get covered by insurance quickly. And so that this is both easy to access from people's home and covered by their insurance plans. And so I just wanted to add those two things.
At this point, we'll open the floor for questions. If anybody has any questions, I'm sure there's, or comments.
Yeah, there is one from Katsura in the chat. You guys can read the most of it, but one of the questions is, while you say that medical care is expensive, I wonder if it would be even more expensive if we're team-based care. So it's an interesting point, but by housing a lot of this under one roof, then patients are, a lot of our services are available to patients through one copay through their insurance. So it's all covered by the same payment. And without getting into too much detail, there is certainly some possibilities for, in the US, what's called value-based care, by reducing the risk of side effects and adverse events, and that it can actually become less expensive. So, but it is something that we're certainly conscious of. And then also, if the patient journey becomes more individualized, each one will require its own solution, and the role of the specialist will expand more. And some doctors are likely to get burnt out. I will, coming from, I worked at a fantastic institution. I was at Emory for quite a while, and it was phenomenal. But I will say that we had, many, many, many neurologists and very, very little support staff. And everybody was working, many, many hours afterwards. So I absolutely understand the concept and of getting burnt out. But I will say the way that we're building things now is really that because we have such a robust amount of support staff, that a lot of the things that really require a lot of legwork, we have people that are doing the insurance approvals and denials. We have people that are working on getting the physical therapy and things like that. So those are happening outside of the clinic visit, so that as physicians, we can really just spend the time focusing on the patient during the visit, and really focusing on the care that they need, and then talking about what other services that are available as far as clinical trials and things like that. So it's actually been a breath of fresh air. I always tell everybody this is sort of how I always imagined practicing medicine when I was sort of a naive college student. So it's really been rewarding.
Just one thing to add there too is, the number of specialty care neurologists is already, challenging and dwindling. So we know that there are 640 movement disorder specialists in the US and dwindling. And at the end of the day, that sort of the brick and mortar clinics are just not able to do everything. So yeah. Just
absolutely.
So in the chat, Jamie, there's what's the carer, the care partner part of the solution?
So, I think a lot of what we're doing is, so we have, we're looking at expanding services, but a lot of it is really including care partners into the conversations and to the concerns that we have. And Sandra, you're able to speak to this a little bit more, but, really understanding what their needs are and how we can support them as well, because by supporting them, we're also supporting our patients. So really understanding what those needs are. And that's part of the reason for, wanting to have that patient advisory board, because we have those care partners as well to really give us that feedback on, what exactly it is that they need that we can help with.
Yeah, I would just say from my own experience of being the spouse of someone living with ALS and the caregiver for the last 5 years is that I feel as if a lion's share of the responsibility of Brian's care actually falls on me as a spouse. So even with Brian and I having access to the very best neurospecialty clinics and care in the country, I still manage the majority of Brian's medical care. I still am the one who seeks out the physical therapy options that can come to the home, the OT, the off-label therapy recommendations that I collate and stick together from various different opinions. I mean, the amount of responsibility and burden on me as a caregiver is not a systemically sustainable solution that we have all been carrying unfairly, and that is addressable, and which is obviously why Brian and I undertook this effort. And I just wanted to add that one of the things that inspires Brian and I is that there are others in the healthcare industry who see the need for this in a very significant way. The company is backed by Google Ventures, which is the lead backer of health tech companies in oncology that have done the exact same thing for cancer patients. So we have incredible support and backing to build this out in a substantial and long-term and reliable way for families in neurodegenerative diseases.
So you have a very captive audience here. Many of them are in the US and many of them are international. What are you looking for from this community today?
Yeah, I think that it would be tremendous if this community would be able to share what we're doing with Synapticure. We can obviously share tonight on the Twitter Spaces event. So I think first and foremost, if you're able to share with your community and your network that we're having that event tonight so people can directly hear from us about the program, that would be amazing. Larry is hosting us, it's the Larry and Brian and Jamie show, but we're looking forward to it. And then if you're able to let your community and network know outside of the Twitter Spaces event, we can just share, we can write up a quick summary. I know the PD Avengers newsletter included a version of that, and we can do the same with your groups. But truly, at the end of the day, the patient community in ALS has given the care that we've provided a 93 NPS score, which is pretty much unheard of. So we know that we're really making a difference for families. And so what we want to do is to make sure the Parkinson's community is aware that this service is now available for them as well, to just support them in every which way.
Are there thoughts of growing this internationally?
There is the hope and the aspiration to do so, but we are focused on the United States currently.
All right. Will you lease out this model to somebody who wants to start it somewhere else?
We will, yes, connect us and we will talk. Yes.
Okay, great. Who else has questions? Comments?
Sorry, Larry, could I ask a question, please?
Sure.
Thank you so much, Sandra and Jamie. Very, very interesting. I'm just thinking about how we could really link your work to our work in Africa. I mean, it is really screaming for something, a service like that, where we could really, we've got so many patients or people who benefit. Perhaps maybe at some point if we could just have a conversation and see how we could really connect synergies, even if it's just really looking for funding to work together, and just to explore really what the possibilities are. And I'll be working with a lot of occupational therapists, and there's an organization in South Africa who focus on occupational therapy, and with the right approach, we could potentially write a bid to almost replicate your model in a small part of Africa, but see if it works. So I don't have your details, but perhaps if we could find ways to exchange those, I'd love to connect and talk further, if that's okay.
I can connect you, Tanya, with Jamie.
Thanks.
Yep,
Thanks.
that'd be great.
Also, Jamie, I don't remember if you put your email in the chat earlier.
I did. Okay. It was, I didn't mean to throw it out to everybody, but everybody feel free to use it.
These are trustworthy folks. I've
that's all right. Yeah, but absolutely, I think it's a fantastic option, and I'm happy to try to connect to. Like I said, I'm on the International Movement Disorders Society Task Force for telemedicine, so I'm happy to connect to with anybody that we can.
That's great.
Thank you.
Any other questions?
Yeah, I've got a question. That was amazing. You guys are on fire, and I love your 360-degree approach. It's just awesome. Sandra, you mentioned democratizing healthcare, which is language that Peter Diamandis uses quite a lot. Are you familiar with Peter at all?
I don't believe so.
Oh, okay. Have you heard of X Prize?
Yes. I've heard of X Prize for sure.
So for anyone that doesn't know what X Prize is, it's a non-for-profit organization that does incentivized challenges to solve global solutions, like global challenges like climate change or AI for good, a bunch of different things. And he's a real pioneer in the health space as well. So he's just developing vaccines, one of which is for Parkinson's and Alzheimer's as well. He's got a stem cell company, genome sequencing. And I think, Sandra, within his community, there's like a whole network that would be really interested in what you're doing and might be able to add value in the tech space, exposure, network, all those kind of things. So
that would be great. Jamie, do you have a thought on just how to, link up?
Yeah. Absolutely. Well, I don't know if you have a connection with them, Amber, or I mean, we can certainly reach out.
Yeah, awesome. I'll email you.
Okay. Yeah, I think you have my email now. So.
Yeah, cheers.
Yeah.
I forwarded that to everybody on Twitter as well. Is that okay?
Yes, that'd be great. If you could put my phone number there too, that would be ideal.
Your social security number, yes.
Yes.
Larry, we are consummate oversharers, so we might joke about it, but it might happen. I just, on that point, Amber, I think that it just was like very troubling to Brian and I to receive what is essentially like the 1% of privileged care because of like our network and our access. And first of all, for that care to still be really lacking, and then to watch everybody around us, I mean, suffering to a degree that is exponentially worse, right? And they can't get into a top clinic. The wait time is 6 to 9 months for a first appointment for these quickly progressing terminal illnesses. I mean, it's criminal. It's unacceptable. And so we feel so strongly. I mean, essentially, 25% of the patients we see today have never seen an ALS specialist. And obviously, we're just starting to learn more about the population that we're going to serve in Parkinson's. But if I told you that 25% of cancer patients don't even go see an oncologist, like through the course of their disease, it's baffling. And this is happening throughout neurocare for all the reasons we all know so well. And there's a way to solve it. So in any case,
Well, let me just say this. Synapticure is inspiring, and it's forward-thinking, and it's going to revolutionize the way what we expect from our caregivers or our care team. Sandra and Brian, you are an inspiration to all of us with degenerative brain diseases, and we look up to you as leaders in this field, and we're happy to be partners with you. And to everybody on this call, I just want to say thank you for everything you've done all year long, because we've made dramatic change in Parkinson's. Just looking over the last year and noticing what all's happened. At the start of January, we had 150 Parkinson's therapies active in clinical pipeline, 54 disease-modifying treatments into trial phases, with 3 going into phase 3. In February, the EPA revoked all food tolerances for chlorpyrifos. In March, Google teamed up with the New York Stem Cell Foundation to create AI software that can diagnose Parkinson's by taking cells from a person's skin. PD Avengers and 100 partners launched the Spark in April. In May, we launched the documentary Long Road to Hope, Ending Parkinson's Disease. In June, the World Health Organization launched the Parkinson's Disease Technical Brief, co-authored by 11 PD Avengers. In September, Joy Milne, the woman who can smell Parkinson's and also a PD Avenger, collaborated with researchers to create a 3-minute test to diagnose Parkinson's. September, also, the National Plan to End Parkinson's Disease Act was introduced to the U.S. Senate and the House in the first ever legislation solely devoted to Parkinson's disease. In October, the EPA asked the federal court for permission to go back and reconsider its decision to reapprove the use of highly hazardous herbicide paraquat, a direct result of the PD Avengers partner Michael J. Fox Foundation and other organizations for suing the EPA for renewing a 15-year license on paraquat. In November, Guy Deacon, the retired British Army colonel, wrapped up his 12,000-mile trek from Sierra Leone to South Africa and the Freetown to Cape Town solo journey. And in December, or just earlier this week, Biogen and Denali's pivotal trial of a first-in-class LRRK2 kinase inhibitor advances to phase 3 trials. So this is a long-awaited test of a target that could provide path to disease-modifying therapies for Parkinson's. That's just a handful of the things that we as a community have been able to accomplish this year. And we all need to be very proud of that. Everything we do matters. And whether it's locally, just something you do in your community, it all adds up. And the momentum is growing, and it's because of you. And I want to thank you for everything that you do for the community. You're inspiring, and I'm really excited for 2023 and what we can accomplish. So with that, I wish you happy holidays. If anybody wants to say any words, feel free. But this meeting is now concluded.
Great.
Thank you.
Thank you so much. This is Heather with LSVT Global, and we wanted to extend a thank you to Parkinson's Avengers, to this group as well, for your help with Google's Project Euphonia, which is working to make voice
recognition software make devices understand people better who have voice and speech changes. And we were able to reach our goal of 400 people participating in 18 different countries. And so it truly went worldwide, and wanted to also share the exciting news that it looks like we're going to be collaborating now. Google has gotten the 5 big tech companies, Microsoft, Meta, Apple, Amazon, to join them, Google, along with the University of Illinois, to continue these efforts to make voice recognition understand people who have various voice and speech disorders. And in large part because of the help that we've received globally, they're starting with Parkinson's disease as their first one to target. So
that's amazing.
Yes. So I wanted a heartfelt thank you from Dr. Amig and I, and we'll be in touch. But this was an amazing sharing of information. I'm absolutely just amazed by the efforts and the presentations today, and humbled. So thank you to everybody.
Thanks, Heather.
Masi had a question or his hand up.
Yeah, Masi.
Thanks a lot. I would like only to say thank you for this presentation, for everyone to make to share with us this. But I hope that will be in the future many Synapticure is arriving in all the world. In Italy, we start with some field of telemedicine, but until it was free, it was used, and after was disappeared. So now there is also many companies try to invest in telemedicine, but I think that it will be the future, but it's very difficult to believe in this, but it will be, is only one solution. And I would like to suggest that it's also important to dedicate attention, to focalize our attention to our child, because few people talk in a webinar about the relationship between the parents and the child, that we need to explain this, and we need also to grow up our child without to conditionate their life, his life, their life, and we need to also focalize our attention to new and young generation, because this Parkinson, this disease is arrive also to young generation. So to talk with new generation and in the school about what is Parkinson, and also to communicate better, which is with young people, because Parkinson is also young, is for young people, and so and unfortunately is not so much is increasing every time in exponential way. We need to talk about this like a new kind of Parkinson that we need to all together. We need to give our help. Thanks.
Thank you. I really appreciate that. Does anybody else want to chime in?
Hey, Brian.
Come on in.
There's Brian.
Hey, Brian.
Hey, kudos to you, Sonia and Tim, for steering the ship for all of us to jump on this year. It's been awesome. And I'm here to say that I should have saw it back at the channel again.
Well, it's great to see you, Brian. It's been quite a year for you.
Oh yeah, it's been a nice year, man. Yeah, it's been a horrific year.
Well, you're always welcome here, and we love having your energy and your enthusiasm, and your never give Parkinson's the leg up. You're always going at it 100 miles an hour.
Hey, you know what Doris said today? I'm not playing it safe, I'm living life. That's damn right.
That's right.
Life.
Thank you.
Thank
you. All right.
Larry?
Yeah.
Sorry. I've got a couple of things. I haven't met everyone, and I didn't mention it before, but my grandfather had Parkinson's. So it's why I'm passionate about it. I've just started a petition to ratify World Parkinson's Day. It's on change.org. I don't know if you guys have heard of that. I don't like the word petition. It's a bit, I don't know, like on the attack, but sometimes you've got to take a stand. It's more a calling to ratify World Parkinson's Day. I will drop it in the chat. I am doing 99 handstands every day for Parkinson's. I'll be honest, there's probably 4 times that I've fallen off the wagon, but I do catch up. So I'm doing 99 handstands every day. And I have found this platform called Mighty Networks, which is basically like, it's like creating your own little Facebook for your community. So there's like a dedicated app, there's a feed, people can run courses. So I was just wondering, does anyone think there's scope or interest or benefit of having a sort of community platform for Parkinson's?
Well, I think there's already, I know the Michael J. Fox Foundation has the Buddy Network.
Mm-hmm.
So that's one platform, I think there's some apps out there now with the PMD Alliance as an app where people have a platform. So I think that's more of a question for the Parkinson's people with Parkinson's and their carers, but I don't know if anybody wants to add to that. Oh, Gabby says they use Mighty Networks. Gabby, can you tell us?
Yeah.
Oh, really? Wow.
Yeah, so we use Mighty Networks at the Davis Phinney Foundation for the folks who are involved with our Healthy Parkinson's Communities initiative. So it's a closed network for those community leaders who are leading change in their community. So we use it very much as a connection platform. We really enjoy that there's the option to chat with folks. There's groups. We've put online courses on there as well. We are still in our first year of using it. And so the only thing I would say as far as considering it for something that's much more broad is it's kind of a heavy lift on the back end for creating it, setting it up, but it's certainly a great way for folks to connect with one another. I think, just like Larry mentioned with the Buddy Network through Michael J. Fox Foundation, something that's really important is having somebody to help moderate and keep conversations going or kind of reel things in. Because typically those end up being like with the Buddy Network, that there's a handful of people who are super engaged. There's a lot of people signed up, but some of that engagement doesn't stay up. So certainly I think an awesome idea. And I'm curious of kind of similar to what was said, like what exists already that maybe we could lean further into, because from our experience, the back end work of it is quite hefty. So, but it is really cool. It's a really cool network.
Yeah, I mean, it's great templating. Like, I like the fact that it's set up for you and you can take the lead on it. You're right about moderation. You're right about the need for a community manager. I just feel like, relying on like a juggernaut like Facebook and doing private Facebook groups and relying on their algorithm to determine your engagement. I just feel this could be like a little bit more on focus. It's good to have your feedback and it's good to know what else is out there, because obviously it's a commitment when you sign up to do it. So I've dropped the petition in the chat.
Yeah, people are signing it.
Oh, are you? Thanks, guys. That's exciting.
Yeah, absolutely. So I'm very curious of how it might align or be different with what already exists, because I think we already battle with duplication of work. So I'm curious how something like that might be different, but absolutely worth exploring. So it's very weird to see my face big.
I know.
Like
I'm trying to get it off. Sorry. I'm not. Oh, there it is. Remove spotlight. Sorry.
No, you're good. It's always, especially because it comes up so abruptly.
Oh, there I am. All right. So does anybody else want to chime in here? Well, we're just sort of hanging out for the holidays. This is like our holiday party. All right. We will, next year, we'll continue these meetings. And we do want to keep them kind of like in this vein, where we're trying to solve big issues and help our partners. Hopefully you'll take this as your meeting and reach out to Sonia and Tim and I about the ideas that you want to present to the group and maybe get some feedback on. And then we are also going to be introducing meetings for the assemble meetings, which are for all the members in multiple different languages throughout the year. So we can focus in and get to know the different, if we're going to be an international organization, then we have to present ourselves as one. And so we really feel it's important to meet people where they are as often as we can. And so we're going to, Sonia, I don't know if you have any updates on that, but I think our first ones are in January.
Yes, with our German friends. The first one's in January, and hopefully Italian. I think Massimiliano, I had sent you an email about that, setting that up for January as well. And Japanese is in the works, and French is in the works, and so we're
working it.
Yeah.
So it's been it's been a great year. So thanks again, everybody, and don't forget to the registration for the World Parkinson Congress in Barcelona is up and running. Hotels are open. Also, if you're thinking about putting together a poster, the deadline is January 13th, or an abstract. And then the other January 13th is also the deadline for grant applications to the WPC. There's a lot of grant money there for young scientists and YOPD and also regular, anyone with PD. And then I found out yesterday, or maybe the day before, that the tulip contest, if you're familiar with sending in your picture with tulips to the WPC, the organization that gets the most people to send pictures with tulips will, the top two organizations mentioned as who they're sending them in on behalf of, will get $5,000 to help send more people to the Congress. So if that's a motivator, then get your friends to take those tulip pictures. I asked if I could send in like 1,000 pictures of me, and they said no. But they would put, you could do up to 5 per individual. So if you have any questions, feel free to reach out. And anything else? Tim, do you have any closing words? So Tim is the quiet one. All right, I'll see you on Twitter, or I'll talk to you on Twitter Spaces later today. And hope everybody has a great holiday. And let's come out of 2022 and into 2023 with gusto. All right.
Thanks, everyone.
Thank you.
Bye now.